Hello, everyone. I'm Adithya, a faculty member of Azim Premji University in Bengaluru. Today, I have the great pleasure of interviewing Professor Gagandeep Kang. She is a physician scientist who has worked on vaccines and public health, particularly focused on children and gut infections in India. She is based at the Christian Medical College, Vellore, for 3 decades, where she's established the national rotavirus and typhoid surveillance networks to establish and estimate the burden of diseases and also test vaccines and inform policy. She is now director in the global health team of the Bill and Melinda Gates Foundation. Her team supports vaccine development against intestinal virus and bacterial pathogens. She is the first Indian woman to be elected as a fellow of the Royal Society. She received the prestigious Infosys Prize in 2016 and is co-author of the best-selling book Till We Win, India's Fight Against the COVID-19 Pandemic. Welcome, Professor Gagandeep Kang.
Thank you, Adithya. It's a pleasure to be here.
First question, which is something that I just thought will be interesting to learn. So microbiologists have this very interesting opportunity of observing organisms that are so deeply affecting the life of millions of people in India and across the world. But these people and the average person has never had a chance to see these organisms or to learn about them. As a person who has observed these microorganisms so closely, is there one that is your favorite?
Well, I have to say, obviously, that my favorite is rotavirus.
Right.
I've spent a career working on that.
Right.
For one of the things about looking at microbes, actually being able to see them, is you get to see an order, a shape that tells you how beautiful the invisible world really is.
Right.
And it is the interactions of the invisible world with everything that we see that results in many, many good things and some bad things for us and for our planet.
Oh, that's definitely a very interesting perspective on how we can think about the microbiological world, and a world that definitely most people are not seeing. And rotavirus is probably one of the very small organisms in this in that world. So that maybe makes it a little bit extra special. Is there something about the shape or the behavior of the rotavirus that you think is particularly interesting?
Well, rotaviruses can only be seen with an electron microscope.
Right.
So unlike many bacteria and parasites, which you can see with a regular light microscope, most viruses will require a much higher magnitude of magnification. And that's why you need electron microscopes to see them. Rotavirus is called rotavirus because it is a wheel-shaped virus. It's a virus that actually has 3 layers of protein that make up the shell of the virus, and then it has spikes on the surface that look like the spokes of a wheel.
Okay.
So it is when you do a reconstruction, you can color your viruses in many different ways.
Right.
And I think that just adds to how they look visually. But it is a very regularly ordered structure. And that's appealing to any student of biology or geometry.
It's very interesting. Thank you. You were trained in medicine and in microbiology, and you have been involved with so much interesting work over the past several years. And your journey has kept you moving between the lab and the field. So even, for instance, as part of your TED Talk, you had mentioned about interaction with clinical trial participants. So, and also you have been involved with setting up these surveillance networks. So you have been involved with people as well as part of your work. So is it usual for a microbiologist to be involved in these sorts of activities?
Well, in India, it frequently happens that once you decide you're going down the route of training in microbiology, that you will spend most of the rest of your life in a lab.
Right.
And for me, I think the uniqueness of training in first medicine at CMC Vellore, where your grounding is very much in the community, and then moving through microbiology to the Department of Gastrointestinal Sciences, it was very easy to make the link between people, microbes, and the gut.
Right.
And then bring it all together in thinking about public health and the impact of those microbes on our health and on disease. So that sort of led me into water and sanitation as well. And I know you have an interest in the environment,
right.
But my own interests started from thinking about, in villages at the time, most people were getting their water from open wells.
Yes.
And any time we tested an open well, we could see that there were a lot of microbes in there that were capable of causing very serious infections, especially in young children. So that's what sparked that interest in linking public health to microbiology and to medicine.
Okay, so there you mentioned about the importance of the institutional structure or paradigm that allows the students to even think, about how we can make these sorts of linkages. So it was the institution that was also very important in shaping how you think about the field of microbiology and its relation to the world.
Absolutely.
Right.
I think institutions are truly our alma maters. And it is the spirit of the institution that you imbibe when you spend a significant amount of time there. And we have a few institutions in the country that are really, really special.
True.
CMC Vellore is definitely one of them.
Yes.
But there are many other institutions that also allow their students a degree of freedom and immersion in a culture that is about caring for the world.
Very interesting. So it was for you not a major shift in how you are approaching your work in terms of linking public health and microbiology. It was not that big a shift, you would say.
Not at all. I think, it makes sense. You have to look at the big picture of what the world is and then see what role you can play within that. And to me, spanning different fields was something that I could uniquely do at CMC.
That's very interesting to hear. So I think that's probably an important sort of message for how people are thinking about medical education as well, I imagine, in the country. You mentioned about water and sanitation, and this is something I was thinking about when I was told that I'll have this opportunity to speak with you. Diarrheal diseases in children, have been the major focus of your work. And on the other hand, if we look at what has happened over the past 30 years in our country, for example, we see that access to water has increased, potable water has increased quite dramatically. Sanitation has been a major sort of focus of the recent governments that, that have been in power. And these programs have ensured that access to sanitation has also, really spread all across the country. Overall, what we have noticed is child survival has improved quite dramatically. And so in this context of all of these changes that have occurred in the country, what would you say is the importance of working on diarrheal diseases at this time?
If I was starting over,
right,
and if I could predict what the world was going to be like 30 years later, I would probably have chosen to work on tuberculosis because that is the most significant unsolved infectious disease problem in our country today. But thinking about diarrheal diseases, at the time that I started out, our infant mortality was much higher.
right,
And in terms of causes of death in children under 5, diarrhea was neck and neck with pneumonia and respiratory infections at about 15-16% of all deaths. Now, a lot of improvements have happened, as you said, in water and sanitation, in the ability of people to access ORS, which can be used to treat diarrhea. And diarrheal deaths have declined. They are still about somewhere between 6 and 7% of deaths in under 5. But respiratory infections haven't come down quite as much.
True.
What has changed for infant mortality is that the bulk of infant mortality is really around the perinatal period. So in early neonatal life, you get almost 40% of deaths are happening at that time. So many things have changed. I don't think diarrhea has gone away.
Yes.
It has significantly declined, and to me, this is a public health success story. What we want is to put all of us out of business, right? There should be no need for us to work on problems like diarrhea, because they will be things that have been handled. But beyond diarrhea, there's also the question of gut damage that happens when children have diarrhea, and especially repeated episodes of diarrhea. So one way of looking at whether you still need to work on enteric infections is actually nutrition. So as long as about 30% of children in our country are stunted and an additional proportion are wasted, we know that children's guts aren't working the way they are supposed to be. And much of that is because they are either not getting enough nutrients, which can be acute malnutrition, but also chronic malnutrition, in which what we are seeing today is that children are getting enough calories, but their guts are unable to absorb all of the nutrients that they need, and that results in stunting or chronic malnutrition. So if we could prevent the infections, could we actually protect the function of the gut, which is to absorb nutrients? And then, you know, growth and development have long-term consequences for people. So we know that if a child is persistently stunted, not only do they not develop physically, they also do not develop cognitively. And that can impact their education, it can impact their earning potential in the future. So the gut has lots of consequences.
Very true, very true. Yeah. So it's interesting you say that 6% of deaths are still due to diarrheal diseases. So it's not insignificant for sure. But very interesting to also hear the implications of not preventing these diseases as well. The long-term consequences, very, very true about the impact on nutrition and its long-term implications in terms of cognitive and physical development. And gut microbes, I think, is one of the fields that is evolving right now, and people are trying to really understand our relationship with gut microbes. And the more we study, we see that they're essentially a part of us at some level. And when things are not well in the gut microbiota, there are a lot of problems that we do land up facing. So in that context, what might be the role of a microbiologist when we talk about this?
Well, there is a lot of interest in the gut microbiome right now. So I spoke about nutrition, and obviously a disordered gut microbiome can significantly affect the absorptive capacity of the gut. But as we work on the gut microbiome, we are learning that the gut actually influences many other organs in the body. And it does that not only directly through the microbiome, but also through the effects of the microbiome on the enteric nervous system, which then communicates with many other parts of the body. So you can think about signaling mechanisms across the body that actually arise from the gut microbiome. Not only that, there are also direct effects that we see. So for example, if you get a vaccine that is injected into you, the composition of your gut microbiome can influence how your immune system responds to that vaccine. This has been shown in animal studies, it's been shown in humans, but it seems really weird to say that, you know, if you need a flu vaccine, make sure that your gut is okay first.
True.
But that's what seems to be coming out of all the explorations that people are doing now.
Right. So a lot of mystery to unravel in terms of the role of the gut microbiome, even in terms of our immune response to vaccines and other things.
Oh, and in in thinking about psychiatric conditions as well,
Right.
your gut microbiome appears to be playing a role. The big question really is, can you actually modify the gut microbiome and then have an effect on disease? And that, I think, sounds conceptually easy to do, but in practice is going to be very hard to achieve.
Right. So we definitely look forward to that sort of work to help our understanding about how this is important. So, I mean, you mentioned vaccine, influenza vaccine, and how the gut microbe is linked to that. So, amongst the many research projects that you have been involved in, I make it that one of the more important ones was the rotaviral vaccine trial that you were very much part of. And you also spoke about it in your earlier talks about how this has been important. Even with your position now with the Gates Foundation, you're looking at vaccine development for enteric infections. So, what are the main insights you've been able to draw in terms of vaccines as an intervention for public health challenges in India?
Well, let's start with vaccines as a whole for the world.
Right.
Anytime you can prevent a disease instead of having it, I think that's a good thing. Vaccines have been around for a little over a couple of 100 years.
True.
And with water and sanitation, they are among the best public health interventions we have. If you think about it, 125 years ago, Indians had a life expectancy of less than 25 years. And the bulk of the deaths that we saw at the time were really because of infectious diseases. We were able to develop vaccines for the major infectious diseases, and that has resulted in our ability to survive for much longer. We have over a dozen vaccines that are now being used in public health programs in India.
Right.
And I think if we could introduce more vaccines, we should. And we should also think about what can we do with vaccines to protect people that are not just school children. We saw what happened with COVID. The country was able to do an absolutely incredible job of vaccinating the bulk of the population. Could we apply that same intention and commitment to thinking about what other vaccines could benefit parts of our population? The elderly, for example.
Right.
Why don't we give them influenza vaccines? Why don't we give them RSV or pneumococcal vaccines when we know that respiratory infections are a big cause of mortality in the elderly? So lots of potential and lots for us to do.
Right.
You did ask me about enteric vaccines, and I think enteric vaccines also have more potential than we are using at the moment. Rotavirus vaccines have been a great success story. But in India, we have typhoid, we have cholera, which are enteric infections. Vaccines are available and we are not using them. So still a long way to go in making sure that we prevent disease.
Specifically about enteric vaccines, is it common for enteric vaccines to be used in other countries as well? Maybe high-income countries, for example. Are they also routinely using rotaviral and other enteric vaccines?
So, in fact, rotavirus vaccines were introduced in the US in 2006. In India, we only had an introduction in 2016. And the arguments that are made for introducing vaccines like rotavirus in developed countries are different. There, the idea is not to prevent deaths. For us, when we introduce a vaccine, the goal is still, can we prevent deaths?
Right.
But in places like the US, no children die of diarrhea, right? So why would they want to use a vaccine? They use the vaccine because it prevents illness, it prevents hospitalization of children, and therefore it prevents healthcare system costs. And it's been estimated that using vaccines actually saves the healthcare system money because you then don't have to treat illnesses.
Right.
And that is true across the world. Vaccines are cost-effective interventions, especially for viruses. And using vaccines is an overall benefit to your healthcare system. Of course, in India and in Africa, these vaccines are preventing children from dying as well. And that's something that we should all be working towards.
Okay, so that's definitely a very interesting perspective, because people would ordinarily think about vaccines as an intervention to prevent deaths. At least in India, that's how we tend to look at many of these vaccines. But they have used these vaccines in high-income countries to also prevent disease. At one level, maybe there is an economic argument, as you mentioned, to reduce the burden on the health system. But is there any long-term benefits for the children as well in terms of not having these infections? You mentioned about the gut microbe. Is there something on those lines that might also be something worth thinking about when we use these vaccines?
Well, there are the direct effects of vaccination, which is preventing disease in the people who receive the vaccine. And there can be long-term as well as short-term effects. I mean, one of the things that vaccines do is if you're not sick, you actually go to school and study. So the absence of illness has many advantages for a child. But one of the things that interestingly happened with rotavirus vaccines being used in the public health program in the US was that they found that adult diarrhea came down. And diarrhea in the siblings of children who got rotavirus vaccine also came down.
Right.
So, and those were indirect effects. And it was only after they measured this effect that they were able to figure out that the reason that this was happening was because children, very young children, are the transmitters of illness. So if they don't get sick, they don't transmit within their families. And that results in less diarrhea in the community overall.
Right.
One of the problems, of course, is that, rotavirus vaccine is an oral vaccine. And it works beautifully in the US, the UK, and Finland, you name it, high-income countries. But it doesn't work quite as well in developing countries where we have damaged guts. So if you look at India or Africa, if the vaccine prevents 90 to 95% of disease in the US, it only prevents somewhere between 40 and 60% of disease in India and in Africa. And that is an issue with the performance of oral vaccines. It's in fact something we've seen before with polio vaccine. We've all seen national immunization days where all children under 5 have to be given vaccine.
The pulse polio campaigns.
Pulse polio programs. And that is because in India and locations that are like India, we need to give many, many more doses of vaccine to achieve the same effect that the high-income world, the industrialized world, was able to achieve with just 3 doses of vaccine. It was calculated that, 20 years ago in UP, children were receiving anywhere from 20 to 40 doses of oral polio vaccines. But it took that kind of effort for India to wipe out polio, but we did it. If we had healthier guts, we could have done it with less.
Okay, that's definitely a very interesting insight about how, the gut health also affects our response to some of these vaccines. That's very, very interesting to hear. You also mentioned about the fact that vaccines as an intervention have been underutilized, that there is scope for increasing the number of vaccines. Generally, there is a perception that, vaccines could potentially be harmful as well. This is something that people in the community feel. And during COVID times, there were a lot of, you can say, discussions and debates around the safety of vaccines. And this seems to be an issue to not a great degree in India, possibly, but internationally, we see that people are concerned about vaccines as an intervention. But on the other hand, you mentioned that they are actually an underutilized intervention, and we should be thinking about more vaccines and not less vaccines. What do you feel about, how people might receive this idea of actually increasing the number of vaccines?
I think when people express concerns about vaccines, they are absolutely right to do so. There is no vaccine that I can say is completely 100% safe in absolutely everybody who receives the vaccine. Now, having said that, conceptually, we have to understand something about vaccines, right? If you have a drug and you take that drug because you are sick, if you have a side effect of the drug, you accept it because it's making you better. So, for example, if you take antibiotics, if you have typhoid, then the antibiotic gives you diarrhea.
Right.
You think that's all right. At least my typhoid is getting cured, my fever is coming down. So you accept the side effect because you're sick. When it comes to vaccines, vaccines are given to healthy people. There is no reason for a person to take a vaccine at that time. You're taking the vaccine as insurance that when I get the vaccine, I won't get sick if I am exposed to that infection. So the bar for safety for vaccines has to be much higher than the bar for safety for drugs. So that's why vaccines get tested very, very rigorously. So if a vaccine is given as an injection and it causes too much fever, or it causes febrile seizures in children, then you're not going to progress too far with that vaccine. So anything that is a common side effect, if the vaccine causes too much of that, you're not going to be able to progress that vaccine in development. So any side effect that you see with vaccines, it has to be a rare side effect. It has to happen in, I give the vaccine to 10,000 people and it happens in one person. That's an acceptable level of risk. You're always doing a trade-off between what is the benefit of vaccine, what is the risk of vaccine.
Right.
So, for example, for rotavirus vaccines, when the first vaccine was introduced, it was introduced in the US. They gave out about 1.5 million doses of the vaccine. And then they saw a signal of intussusception, that children who were receiving the vaccine, 1 week after the first dose of the vaccine, they were developing this telescoping of the intestine.
Right.
Now, they had a reporting system which identified that there was a signal. 175 cases of intussusception had been reported in that system. They stopped the vaccine. They said, we need to analyze, we need to see what this signal is. At that time, 175 cases and 1 child had died because of the intussusception in the US. They stopped it, they analyzed the data. At that time, it looked like intussusception was happening in 1 in 4,000 children who had received the vaccine. And they said, we are not proceeding with this dose. At that time, again, there was a lot of discussion with WHO and public health experts saying, but in the US, you don't have children that die of diarrhea. This vaccine is working beautifully. It prevents diarrhea. In places like India, Africa, we have so many children dying of diarrhea that even with the risk of intussusception, the benefit of the vaccine actually is much greater than the risk of intussusception. So can we please use the vaccine in other places? And the decision was made that if a vaccine is withdrawn in the US, it's not going to be used anywhere else. But the work continued to then identify safer rotavirus vaccines. They did trials in 60,000, 70,000 children and were not able to find a risk of intussusception. Those vaccines got licensed. Those were the vaccines that, as I mentioned, that were introduced in 2006. And then people kept on monitoring, thinking, if there was a problem with the previous vaccine, will there be a problem with these new vaccines?
Right.
Even though the big safety studies had been done. So they kept looking, 3 years, 4 years, nothing.
Okay.
Finally, in Australia, they started to see a signal of intussusception with the vaccines they were using, both made by multinational companies and both showing a signal.
Right.
In the US, they studied it for 7 years and then they saw a signal.
Okay.
The signal varies by, location. It's somewhere between 1 in 20,000, 1 in 100,000. In India, we have looked and we cannot find a signal with the Indian vaccine.
Oh.
So it seems to be a variation in geography. Maybe one way of thinking about it is the vaccine works less well in India, but it also is lower risk of side effects in India. Where it works very well, there is also a risk of a side effect.
Okay, that's very
so I think, it is really fascinating, but it also speaks to the fact that, we have to monitor vaccine safety. We have to be able to communicate about vaccine safety. We should never say that a vaccine is 100% safe. We can say that it's safe because it's been evaluated and we don't see major side effects. And then we need to think about, like in the rest of the world, how do you look after people who are actually damaged unintentionally by a vaccine? So, for example, with oral polio vaccines, some children will actually develop polio because of the vaccine.
Right.
Rotavirus causes intussusception. Influenza vaccine can result in paralysis, which can revert, but if you get a Guillain-Barré syndrome, you're going to wind up in hospital for a really long time.
True.
So if these damages are induced by vaccination, just like, vaccine is an insurance for protection against disease, should we not also have an insurance mechanism that protects against unintended consequences of vaccination, however rare they are?
That's very interesting. I think it lays out quite clearly what the role of the vaccine is when we think about it as a public health intervention, and the benefits and the risks and how we think about some of these things. But specifically in terms of administering multiple vaccines, for example, do we have the systems or the technical capacity to think about, there are concerns maybe that if you give multiple vaccines, there are some additional risks that come as compared to individual risks of vaccines, for example. Is there anything of that sort at all that we should be thinking of? Or?
So there's a couple of things there. The first is, can your immune system handle multiple antigens at the same time?
Right.
And one way to think about it is you're breathing in multiple antigens with every breath you take, probably much more than any number of vaccines given to you at one sitting.
Right.
In the food you eat, you're taking in multiple antigens again, much more than you would for any oral vaccine that you take in.
True.
So your immune system is actually fabulous. It can handle many, many things at the same time. So far, there has been nothing to indicate that you should be taking, that fewer vaccines given at a single time might result in a lower immune response because you've given multiple shots or multiple types of antigens together.
Okay.
So there are some interactions that happen, but it's not interactions that cause damage. It's interactions between the antigens themselves that might result in an immune response that's slightly lower for one versus the other. But you can think about it from the perspective of the immunization schedule as well. Right. What are the trade-offs that you're making? So in China, they've decided, not from a point of view of promoting immune responses, but from a point of view of monitoring safety of individual vaccines, right, to make sure that the child comes every month in the first year of life for different vaccines. That way, if there is a reaction, they'll be able to say it's associated with the vaccine that they got previously, right? So they're doing it for safety purposes. But our trade-off is, instead of 3 visits, do you want a child to make 12 visits, right? So again, benefits, risks, trade-offs, part of the game in public health.
Right.
We do have to think very carefully about the consequences.
Right. It was very interesting to hear how you compared our everyday exposure to microorganisms. And that might be one way in which we think about exposure to antigens that are coming in through vaccines. That was very interesting. So moving on maybe to your more recent engagement with Gates Foundation. So the Gates Foundation obviously has been a very important and prominent actor in the field of global health over the past several years now. And they have supported several important initiatives. One of the important initiatives being the Global Alliance for Vaccines and Immunization. And they've in general been recognized for increasing the visibility of health issues on a global stage. And on the other hand, they've also received their share of criticism in terms of the power that they wield, the influence that they might have in how smaller countries or local areas or scientists in these places or public health people in these places might make decisions on what to focus on. And so some people have worried that they have shifted focus from maybe some diseases that needed focus in some local areas. So in this way, they've had both of these sorts of experience. So as a person who's now working with Gates Foundation, how do you see the role of Gates Foundation and similar philanthropic initiatives in the field of global health and development?
Okay, let's start with the principle that the Gates Foundation has, which is all lives have equal value. So everybody deserves the chance to lead a healthy and productive life.
Right.
So let me turn this around and ask you the question.
Right.
What is the need for the Gates Foundation or any other philanthropy? Why do we need philanthropy in health?
Right, right. Well, it's nice that there are people who are concerned about the health of others. I think that's definitely quite a positive thing when you see that everybody is concerned about each other, and those who have resources to think about other people, if they do think about other people and they're putting money into things that they feel are important, it is at some level we can clearly say that this is something that is positive, that is happening. So that's one way in which I might think about how.
Yeah. And I agree with you, because I think what we want in an ideal world is that there should be no need for philanthropy, right? So philanthropy is clearly filling a gap.
Right.
Now you can argue about what the right way is to fill the gap.
Yes.
And the best way to make that argument is actually to go out and fill it. So if there is something where you see an effort that you think is inappropriate for one or the other reason, nothing is stopping anybody else from coming in and righting that balance. It's easy to sit in an armchair and criticize. It's harder to get out there and do the work. And I think that as long as you're having a net positive impact on disease, that is a good thing. But I think it's also important to understand that, the Gates Foundation has a spend of, it's going to be up to $9 billion a year.
Right.
And that's a small part of global health funding.
True.
So if there were more philanthropies that came in, more people willing to do the work, more development banks investing in health, that would be, I think, absolutely phenomenal. And I think there wouldn't be any right-thinking citizen of any country that would see anything wrong with greater investment in public health.
So if I were to understand what you're saying, there is also a role for maybe the local or national government to think more closely about their own priorities. And yes, when philanthropic organizations do approach them to support certain initiatives or bring in certain priorities, there is an important role that the local organizations, local government, local people also have in this conversation in terms of how they would think about what should they set as priorities for their health problems.
Yeah, I think, again, harking back to the foundation's principle of all lives having equal value, the point is to try and raise standards in the poorest parts of the world by making sure that there is investment in public health.
Right.
And if there is a question about how that gets done, well, actually, the foundation itself only works with partners.
True.
Right? So in India, the foundation has the India Country Office, and they align with the government for any initiatives that they undertake. So the investments in UP and Bihar have been with both state and center to decide where help is needed and how the foundation can offer that.
Okay. So moving on to COVID as an important initiative that you've been involved in. Overall, what we were seeing in global health, priorities and perspectives, non-communicable diseases were sort of stealing the thunder away from communicable diseases over the recent past. But the COVID pandemic clearly has brought back a lot of focus on communicable diseases. And during this time, you were very much in the thick of decision making, advising decisions, and also in health communication during the pandemic, and played a very important role, I think, during that time. During that experience, you also co-authored a book that has been very well received about the pandemic and our response to the pandemic. So did this whole, you can say, experience of being engaged so closely with the COVID pandemic and the response affect your notions on how we think about communicable diseases?
Well, I've been in communicable diseases all along, so
True.
I don't think it affected my thinking around communicable diseases, but when the pandemic started, I did think that, there must be other experts in the country that can talk about COVID.
Right.
So there's no reason for me to say or do anything. And then I realized that as somebody who had done both medicine and microbiology and public health, there weren't that many other people in the country that had the experience that I had, especially given that I had also worked on the development of vaccines for a mucosal infection. So conceptually, I had a pretty good understanding of what was going on. I had also been involved in CEPI, the Coalition for Epidemic Preparedness Innovations, where a lot of the discussions around disease X emerging from somewhere and causing disease in a large part of the population had informed my thinking. So I think I was well positioned to work on COVID, and then, as you said, particularly to communicate on COVID. Again, initially I was a bit reluctant because it's never felt like the role of a scientist to talk about particularly their own work. But I realized again that people were pretty hungry for information and credible information that didn't overpromise on what was feasible. So that's the stage at which I started to talk more with journalists and to write in newspapers. But I did make it a point I decided it was my role to be available for people in India. So whether it was trying to speak in very bad Tamil or not that bad Hindi or English, I limited myself to Indian journalists and didn't really want to be talking to BBC or others most of the time.
Okay, so two very interesting insights there. One is that you somehow found yourself with this very unique set of competencies, which and it's not just that you had it, you were also somehow prepared for it, being part of that coalition that you mentioned. Obviously, there were not many people, it seems like, who are even thinking on these lines or ready with these skills and the knowledge that was needed to be ready to offer advice at that stage. Has that changed since the pandemic? And do people now recognize the importance of having these knowledge and skills when we think about these pathogens that can cause pandemics, for example?
I think some things have changed, some things stay the same. So in terms of pandemic preparedness, there is an awareness around the world that making investments is the right thing to do. Unfortunately, that awareness is limited to people in public health and in science. The bureaucracy recognizes it and policymakers recognize it at some level, but they have many other competing urgent priorities on their plate, which means that we are not seeing the kind of sustained commitment and investment that is required for public health. And to me, that actually speaks to the fact that maybe we, as scientists and public health experts, are not communicating what the benefits of that investment in preparedness might be.
Okay. At one level, that does sound a little strange that it wouldn't be obvious that this is important, simply because we saw the impact the pandemic did have, not just in India, but everywhere in the world. So at some level, even as a person who's working in the field of public health, I would think there is actually no need for communication or further evidence that, this is something that needs attention. But it seems to be the case, unfortunately.
I find it really strange because if you look at the amount of resource that gets spent on what is important and necessary for the whole population, right, which is health and education, compared to what gets spent on other things that are public goods. It just seems really odd to me. And how do you do a trade-off between, let's say, having an investment in public health and making a new highway? Even within health, if you think about it, do we really need more tertiary care hospitals, or should we be strengthening our primary care system?
Right.
It also seems incredible to me that our public health system seems to function on what is essentially volunteers. And volunteers that get a stipend but are asked to do a lot of work. When does that change, and what will make that change happen? is, I think, something that we really need to work hard to try and figure out, and then do what we can to make it, influence that happening.
The next question, which I'm interested to ask, is there are these emerging infectious diseases that have been, that is something we're aware of over the past few decades. And even now, we have, for example, the mpox outbreak that's happening in several countries. More recently, in the US, we had the avian influenza outbreak as well. So these are around, and they are threatening a little bit, you could say. And if this is the new normal, and you talk about the new normal in your book as well, so what more should we be thinking about in terms of pandemic prevention more broadly?
So, one of the roles that I have at the foundation is actually to look after public health genomics. And the team that works with me on that has been very invested in the mpox outbreak.
Right.
So they, even before I got to the foundation, had been building up infrastructure all across Africa to make sure that there was genomics capacity in multiple countries and locations. And it was through connections with the work that had been done previously that it was possible to figure out that the mpox outbreak that we are seeing in DRC now is a particular strain that is more transmissible and causes a different form of disease than the mpox strains that had been seen previously. So that speaks to the value of making the investment before the need is there. Right. And that is something that I think is true across the board. And it's interesting that in India, for many things, we have been making pretty good strides in changing our public health infrastructure and landscape. So we all saw that INSACOG was this network of laboratories that did genomics, was stood up during COVID and did an excellent job once it got started of being able to identify new variants as they emerged. But last week I was in Uttar Pradesh visiting an health and wellness center, now called ARM, and met with a community health officer who clearly knew her role and was executing on it really well. And having grown up in Bihar and UP as a child, what I saw there was something I would not have believed possible. There is certainly room for improvement, but we've come a long way in India. And while we certainly have a lot to do, we're making progress.
Right. So this is the importance of having surveillance networks to help with identifying these infections at an early stage. Is that what it is? Or,
So one part of it is surveillance networks, and the other part of it is raising standards of public health.
Right.
I think we are trying on both fronts, and we are making progress. The problem is we tend to be a little bit impatient.
Right.
And I think maybe too much patience is not a good thing. So if we weren't pushing for us to constantly do better, change wouldn't happen at the pace at which it is happening.
Yeah, I mean, indeed, as I also mentioned before, the progress in terms of vaccine technology and other technology as well, but even basic public health infrastructure has improved quite tremendously. And indeed, it's our impatience and our need to ensure better public health for everyone that is pushing many of the things that many people are doing, which is definitely an important thing. But in terms of the pandemic prevention, there is also this idea of One Health that has come into the picture, and the focus of One Health, which has also been on surveillance as an important intervention, but is also to think about how is it that pandemics begin, and anything that you feel is important to consider when we think about that.
Couple of things, right? So usually when we think about pandemics and what's been told to us about disease X, is that you have biodiversity hotspots, you get into forests, you encounter animals, you get this strange virus that nobody has ever seen before.
Right.
It crosses over species and now it starts to transmit between humans, and that results in disease. And that is certainly one form of what we have seen. So SARS-CoV-2 was probably that. SARS-CoV-1 was probably that. In some sense, HIV was probably that. Right? But we also have this other situation now of bird flu. So can you imagine a virus being in cows, in dairy cows and, cattle that are being bred in the US? If the same thing was happening in India, where you had a virus in cows, where you have a lot of interaction between cows and humans, you can see that the spread might be much more frequent, even with an adapted, not as adapted virus as is possible, with just the rate that they are seeing in the US. You could imagine a lot more cattle-human encounters and greater spread into humans than has been seen so far. And the more frequently these jumps between species happen, the greater the chances that viruses will adapt. So we do need to worry about forests and wildlife, but we also need to worry about encounters with domestic animals that may be carrying a variety of pathogens that could potentially adapt to humans.
Right. Okay, so that would be particularly important from India's perspective.
India especially needs to be looking at both animal husbandry as well as wildlife.
More general question about your research experience and your thoughts on research. So you've been so deeply involved in health research, and it would be great to learn your thoughts on the status of clinical and public health research in India. Not just about the quantum of research, you'd say, but also like who is doing this research and what is driving this research. What are your thoughts on that?
In medical colleges, every medical college that has a postgraduate program requires every postgraduate to do a thesis. So by that measure, there is plenty of clinical research that is happening in the country. The problem is, postgraduates are not the right people to be doing research. They are there for clinical training. And some exposure to research methods might have utility for them, but ultimately the bulk of them are not going to do research for the rest of their careers. So restructuring our thinking on research has to start from our educational programs for training doctors. What do you want them to be able to do? And at what stage in their career is this the right thing to be doing? So I would actually prefer fewer people doing research, but doing it better, rather than everybody doing research and everybody doing it badly. So it's quantity doesn't necessarily always make for quality. And what we really need in India is quality research where the questions are specific to our population. You're not borrowing from it was published somewhere else and I will do the study first time in India, which tends to be what a lot of our projects and publications are about. The ideas have come from elsewhere. And then we are just trying to execute them here and saying that because it's our population, it's new. They're not wrong, but that doesn't create a model for us to be able to address our own health needs. it is beginning to happen. So, for example, take diabetes. Now, we recognize that in India, diabetes is much more of a problem here than in most other Western countries.
Right.
So, questions are now being asked about how does diabetes actually influence other diseases? Is there a role for modification of your management protocols? If yes, what do you do about it? But those are the kinds of questions that need to be asked in big, well-powered studies that are well conducted, so that we can come up with protocols that are built on data from our own populations.
Okay.
So more would be great.
Okay, that's definitely a very interesting perspective. When you initially say it would be nice to have less people do better quality research. So at some level, maybe people who are trained in research are spreading themselves too thin by trying to ensure that their postgraduate students are getting a thesis out and eventually never landing up in a research career. So there is some need for rethinking about how we think about postgraduate education, especially in medical colleges specifically, you mentioned, but about the quality of research in terms of the questions they ask. And so that's definitely very interesting. Thank you.
I'd like to make a point here.
Right.
You know, if you think about educational institutions for postgraduate education in the country and maybe doctoral education in the country,
Right.
An MD is a doctorate, MS, whatever.
Yes.
Similarly, a PhD is a doctoral program. When we train students, we train them to be like us and to think about career paths like us. So if you talk to PhD students at an academic organization, every PhD student thinks that they are going to become an independent researcher, PI. They are going to go and again work in another research institute or teaching institution. We don't expose them to what is possible outside that field.
Right.
That a PhD could be in law or in management or in consulting or some other field as well. Those things tend to happen by chance. So I don't think we're using our educational platforms very well.
Okay.
Similarly, if you think about medical colleges, when we train MDs and MSs, we require them to do a thesis.
Yeah.
The faculty have to have X number of papers to get their promotions, etc. So we are training in the model where we think everybody is going to become a faculty member and do these 2 or 3 or 5 or 10 small projects for various things. But the bulk of doctors are not going to wind up in a medical college. They're going to wind up in hospitals. They're going to wind up in private practice. Why aren't we equipping them with financial management instead of research to make them more successful in their careers? The ones that really truly want to do research should have to come and find it, and then we need excellence in the institutions that are engaged in doing the quality research.
That's true. Definitely, many of us felt the lack of basic life skills after we finished our undergraduate and postgraduate education. What about public health research? So, CMC, of course, is quite a unique place where you do have a department of public health as well. There are master students of public health and epidemiology. For a long time, these programs have been around. But in general, any thoughts on public health research as well in the country?
Public health is a very, very large field, right?
Yes, yes.
So you can come at it from many different angles, whether it is economics or policy or environmental studies or aspects of screening people that might be very relevant. And when you think about a country like India, the way I think about it is referral pathways. If you start with the population and you can stop disease in the population, so then you don't need to escalate that disease to the next level of care. Overall, there has to be a good payoff with that happening. What tends to happen now is for relatively simple things, we wind up in a tertiary care hospital. So, for example, for women who have a normal delivery, why no risk factors, nothing? Why would you want to deliver in the biggest hospital in the city? You should be delivering as close to home where your family can spend time with you, but you have the ability to call on expertise when you need it, right? So if we think about, I have cough and fever, do I really need to go see a doctor in a hospital, or can I just go to a primary care nurse who can tell me what to do, right? So I think in public health, it's keeping people out of hospital as much as possible. And then within hospitals also thinking about what are the approaches that downgrade the level at which you need to seek care. So you're really keeping tertiary care hospitals, the fancy stuff, for people who really need it.
So is there a need for more research-minded practitioners at a smaller geographical scale? You think that something like that is...
I think, India is humongous. Our population is huge. What we should be thinking about is at state level, what are the questions that are important? What are the right partnerships that need to be made to ensure that we can address the questions that are truly important for the people in that state or even at a district level?
Maybe just the last couple of questions about some broader reflection. So I had the opportunity to see a nice interview that you gave a couple of years back with another faculty member in Azim Premji University. I think you were speaking to the biology students. And so you mentioned about the importance of respecting people, that people in the sciences should learn to respect people and the knowledge that people possess. You also mentioned about how microbiology was like detective work as part of that interview. And of course, more recently, I've seen you have written about universal health coverage as an important intervention or a goal that we should have in terms of, for our country. So broadly reflecting on your experience and your thoughts on the future of public health and medical care, what would be your message for medical and public health community in India?
I think I'm nobody to give anybody messages, but if I was to reflect on what I think we should be doing in public health, I think it is providing people the care they need where they are, instead of expecting them to come to us. Kind of builds on the theme of what I told you before, which is if you're thinking referral pathways, it should be a truly need-based referral pathway. If you can push things to where people are, that makes a lot of difference. And much of this thinking actually came from the first research clinic that I set up.
Okay.
I was going to do this study that was going to look at a birth cohort of children that were going to be followed up for 3 years for all diarrheal disease, trying to identify a correlate of protection for rotavirus. So it was really looking at immune responses in children. But we started with recruiting mothers when they were pregnant. One of the things that I wanted to do for this cohort was to collect cord blood. So that I wouldn't have to bleed the child when the child was born. So in order to collect cord blood, the woman has to deliver in a facility where you can collect the cord blood. In my naivety, I thought that telling all the women that if they came to our hospital, very nice hospital, that would be something that they would want and they would happily come there. I did not realize that delivering at the hospital requires 4 antenatal visits. This hospital was 5 kilometers from where they lived. Not huge in terms of seeking healthcare in India, but for people who are daily wage workers, taking a day off to come to a facility, wait in line there, even if I have people facilitating that, that actually means a loss of a day's income for them.
Right.
And you lose enough days of income, your contractor will stop employing you. So what we had to wind up doing was to work with the urban health center. And when I first went to the urban health center, I asked the doctor there, if these women come to you for delivery, will you be able to do this? And she said, fine. And I said, look, I have some funding in my research project, which I was going to use to pay for their delivery costs in the main hospital. But instead, why don't I give it to you and you use it for what you want?
Right.
And we started like that. We started with buying them Macintosh sheets, buying them cotton gloves, a new fridge to put things in. And once they had the resources they needed, many of the women were really happy to go and deliver there because the quality of the care they were getting went up just that little bit. So it played out like a win-win situation. The women are happy because it's local. The health facility is happy because they've now got resources, and everybody feels good about giving better care to the people you are closest to.
Right.
So why don't we just do more of that?
Very interesting. I think even as public health, when we think about populations, we start thinking about very big populations and state, country, or world. Now we talk about planetary health, and people are really zooming out as far away from people as possible at some level. But I think your example really shows us how the importance of connecting with local populations should be at the center of how we think about public health. One last question in relation to this as well. So more recently, there have been discussions and a recognition of the role of women in science and in research. So what would you like to tell women in public health practice and research?
Women in public health practice and research are as heterogeneous as women anywhere. I think in India, many of us who have received a good education are very, very privileged. Right. We have the ability to compete within our country and globally on pretty much equal footing. There are always disadvantages to, the language you speak, where you come from, etc. But our education is really sound if you received an education in, reasonably good schools and reasonably good colleges. There are other women that have a much harder path that they have to follow. And then I think it is the responsibility of those of us who are privileged to make sure that anybody who has not had it as easy as us, you actually reach out and help support the ones who need that support, because the potential in India is just phenomenal. We have so many good people capable of so much, and sometimes all they need is a little bit of help, and we have the ability to give that to them.
Thank you so much, Professor Gagandeep Kang, for spending this time to enlighten us about your journey in public health, and wish you all the best for your work.
Thank you, Adithya.